In a second. All right. Hi, everyone. Good afternoon, and welcome to another SJMC Grand Rounds. And this is the first of our CPD, live CPD coming to you on Facebook and YouTube from SJMC, the halls of SJMC. But you'll notice the backgrounds will all change for, we have a little bit of something different this time. So before I introduce my esteemed colleagues, just want to remind you, those of you who are watching on the DOBBS Facebook, please don't forget to like the video so that your other colleagues on Facebook will be notified, as well as on YouTube. If you can like the YouTube video, don't forget to subscribe to our channel and hit the notification bell, as you say in YouTube, so that you'll be notified of our upcoming events as well. Okay, now I just want to go through some housekeeping slides. All right, so this is the 11th of SJMC Grand Rounds, and this is actually part 2 of the obesity talk. You'll find part 1 in our playlist if you go to our YouTube webpage, and part 2 we are talking about NASH and what it's got to do with heart. So now, as usual, we would like you to ask questions using Slido. All right, and please join us on Slido. The code is slido.com. Code is 777582, or you can use your normal QR code scanner, not the MMA app, please. There's a normal QR code scanner or your camera, and then it will take you to slido.com and automatically put 777582 there. So you can ask the panel the questions in Slido, okay? Then at the end of the session, we will display the QR code, and this one you can scan with your MMA app using the thing in the red circle. Tap on that scan there, and you scan the QR code. Now, this code will be displayed in the white space below. All right. So I'm going to now switch over to my colleagues. All right, and I'm going to introduce you to the moderator, none other than Dr. SP Chan. Okay, who's put up a hand there. So over to you, SP.
Right. Good afternoon, everyone. Welcome to Obesity Part 2. And my co-chairperson is Jayamala, because after all, this is what has got to do with the heart. Absolutely. And then with us is Dr. Ganesh, who is a consultant gastroenterologist hepatologist, and the chief dietitian of Subang Jaya Medical Center, which is Nurul Nazia. Welcome, both of you. Right. So in the usual manner, we are going to set the scene. You've seen this with the first obesity part 1, where you can appreciate, unfortunately, this is the regional statistics for obesity, and unfortunately, Malaysia is the champion. When looking at the percentage and proportions of our population, this was from the census that was conducted in 2019. 20% of the individuals were obese when using a cutoff of 30 kilograms per meter squared, and 30% overweight 25 to 29.9. And so that makes 1 in every 2 adult persons in Malaysia with either obesity or overweight. How does that translate in terms of proportions of people with fatty liver disease or NASH for that matter? And here is a study that was conducted in the University Malaya Medical Center by the gastro unit there, and they were able to scan a whole bunch of almost 600 individuals with a mean age of 61, that the prevalence of non-alcoholic fatty liver disease was, depending on which methods were used to identify them, 50% by ultrasound, and by, this is controlled attenuation parameter, if I'm not mistaken, is by FibroScan, is almost 3/4 of patients who are attending the diabetes clinic in PPUM. So it's not a small problem, and I think it is about time that we woke up to this particular abnormality. And so that's the reason why we are bringing it up to you today. As usual, we usually highlight some of the issues surrounding this topic by using cases to illustrate the problem. And here we are, Dr. Ganesh, I'd like to present to you a 34-year-old man who went for a routine medical examination, and he comes running to you and says, Dr. Ganesh, I have this term abnormal liver function. I don't understand. I feel so well, Dr. Ganesh, and this is my result on the right-hand side of the slide. Dr. Ganesh, what would you focus on? What kind of history might you want to obtain, physical examination, and what other investigations would be appropriate in this particular patient?
Okay, thanks, Dr. Chan. I think this is a very common scenario where you get somebody who just goes for a routine medical, does a whole series of tests, and they end up finding that their liver function is deranged. So we look at this patient. He's a 34-year-old gentleman who, the common reason for a deranged liver function would be fatty liver or non-alcoholic fatty liver disease. So the first thing you want to do is to find out what are his risk factors, and does he have any risk for metabolic dysfunction or any of the metabolic disorders. So you would want to find out whether he's got any medical conditions like diabetes, does he have high blood pressure. You're going to ask him about his lifestyle. Does he consume alcohol? If he does, how much alcohol does he consume? What type of alcohol? What amount? You want to also ask him whether he smokes. Find out whether he's got a family history of liver problems. Other relevant things like, has he had any form of blood transfusions? Because deranged liver function, although fatty liver is the commonest reason, there could be other reasons like hepatitis B or hepatitis C. Hepatitis B is very prevalent in Malaysia, and although we started our universal vaccination in 1990, and we are seeing less and less of patients with hepatitis B, it is something we are still seeing a fair bit of. Hepatitis C is also another thing. Although we started screening all our blood since the early 90s, people prior to that could have had hepatitis C. And this is something worth picking up simply because they're all very, very treatable. So of course, you also want to find out what is he active physically. And on examination, you want to look at his body habitus. What's his BMI? Is he overweight? Does he have what we call truncal obesity? Does he have a big waist? In which case, we find that these are people that tend to have a fatty liver because they tend to have a lot of visceral fat. And other investigations will really be looking at two things. One is to exclude other causes of his liver disease, i.e. making sure you're not missing a hepatitis B or a hepatitis C that's very treatable. You're also going to be screening him for any metabolic dysfunction, looking at sugars, looking at his cholesterols, looking at his specific things like his triglyceride levels and his HDL levels to see whether he's got any other risk factors for metabolic dysfunction.
So you're saying that this man is likely to have all the features of a person who has got metabolic syndrome. So with all these other features, that might also increase his risk for cardiovascular disease. Is that right?
Yes.
Okay. So here we are. He tells you that he plays futsal only on the weekends. He smokes, enjoying life. Alcohol, 3 glasses of beer. Does that is that constituted as alcoholic liver disease? Perhaps you might want to mention, talk about that. BMI is 29. That places him in obese by Asia Pacific standards. And the ultrasound is as written there. The hepatitis antigen is negative. HCV is negative. Dr. Ganesh, what next?
Okay. So going back to the question of alcohol, the question is when is it safe? How much is safe and how much is not safe? So the general consensus is in a male, up to 3 units a day is acceptable. Up to 2 units a day. And women, 1 unit a day. Okay, that's considered acceptable. But having said that, the jury is still out on what is actually a safe limit. So if you think your patient got significant liver disease, abstinence will probably be the best advice. And at one time it was thought that some amount of alcohol is actually protective against cardiovascular diseases with alcohol, but that has not been found to be in the cases of patients with NAFLD or NAFLD liver. Unfortunately, no. So the general consensus is probably the lesser the better.
Okay. So what about the ultrasound abdomen, Dr. Ganesh?
Okay. So it's ultrasound abdomen, quite typical, fatty liver. So basically what it means is that when they look at the scan, the liver is brighter than the kidneys, and that's a typical fatty liver. An enlarged fatty liver is not surprising. But having said that, ultrasounds can only pick up the fatty liver when there's more than 20% fat.
More than 20%?
Whereas the definition of fatty liver is you must have more than 5% fat. So there is a small percentage of people where you may not be picked up on an ultrasound.
So there is underdiagnosis, you're saying?
Yes. So you need to use other things if you strongly suspect.
Can I ask you about the liver enzyme status? Does that sort of like spark a lot of worry in you when you see an AST and ALT at that level?
Not surprising in somebody who's got fatty liver, but there are a large proportion of people with fatty liver where their liver function is plumb normal.
Yeah.
So a normal liver function does not exclude fatty liver. So you tend to be more cautious in somebody who does have metabolic dysfunction, who's got metabolic risk factors. These are people you may want to be a bit more thorough even if their liver function is normal. And one of the clues to look at when you look at the liver function is subtle things like looking at albumin. If the albumin is normal, the globulin is not high, their ALT is more than their AST, these are things that makes it less likely that these people have a significant fibrosis or they're heading towards cirrhosis. Having said that, liver function is not a very sensitive marker of scarring, and you can have cirrhosis of the liver with a perfectly normal liver function, which is why you can easily miss, and you would have to use other modalities if you have a high index of suspicion to actually rule out liver cirrhosis or significant fibrosis in the liver due to the fatty liver.
So let me just get that right. You say that if the ALT is higher than AST and normal albumin, that it is more likely that he's got just simple fatty liver. Is that
correct?
Okay.
Yes.
But the converse is not true.
Yes.
That means if it is completely normal, it may still not pick up a person with fatty liver disease. Is that right?
Yes.
Okay. So now you've asked for his metabolic profile. I'll say that his lipids are typical metabolic dyslipidemia, low HDL, high triglycerides, and his fasting glucose is 6.4, 6.1%, A1C. That places him in plumb, right in the middle of having what we call pre-diabetes, right? So what is your diagnosis, Dr. Ganesh, after seeing all these results?
So the thing about dealing with fatty livers, is this a simple fatty liver or is this something called NASH? And the only way you can tell the difference is actually by doing a liver biopsy. And while we're at the topic, one of the things that we are moving towards is trying to relabel NAFLD because non-alcoholic fatty liver disease is a diagnosis of exclusion. So you really make sure that there's no significant consumption of alcohol, etc. So there's a lot of movement towards is a renaming of MAFLD, which actually stands for metabolic dysfunction associated liver disease. The reason being wanting it to be a positive diagnosis, which means if you do have a metabolic dysfunction in the presence of fatty liver, then we would we're starting to call it more and more as a MAFLD.
Okay. So again, let me just go back to being pedantic here a little bit. You said alcohol, 2 units per day for an adult male, beyond which there's a potential that there may be some alcohol contribution to this problem. Can you have a combination of problems?
Yes, not uncommon, and that's why we're moving from methyl to methyl.
Okay.
So in methyl, you still have it. So it doesn't mean that you don't drink or very drink. It's sort of not necessary for you to not be drinking. So you can drink a fair bit, but you could still have significant fatty liver or injury from the fatty liver due to your metabolic derangement.
All right, good. So now that we agree on the diagnosis, he's got NAFLD, he's got pre-diabetes, he's got all the features, his android obesity, what you just described, the classical Apple obesity. He asks you, what next, Dr. Danish? What can you offer me? So I would like to ask you about, I know you will talk about lifestyle, but I'd like Puan Nurul to come in on that. What about medication? What about these liver tonics that they have out there?
Okay, I have to, unfortunately, most of the time you have to tell them to do something that's the hardest thing to do, which is to lose weight. Okay, so unfortunately, supplements is a quick fix, but unfortunately, it's really, the results are quite disappointing generally. So there have been a lot of supplements in the market. The commonest you would see is really something like Silimarin. Comes in different forms, in different brand names, and basically Silimarin is from milk thistle plant, Silimarin and Silibamin, and they're both really antioxidants and anti-inflammatory. But most of the studies have actually generally showed a reduction in the transaminases. There's one study which was done in University Hospital in presented in 2017, where they actually gave patients high doses of Silimarin, and this is one of the good meta studies where they biopsied the liver. And they did show that it seemed to have, and this was in patients with NASH, where they found that there was actually some reduction in the fibrosis. Although, when you look at the biopsies and you look at something called the NAFLD activity score histologically, well, they did not reach any statistical significance, although there's some reduction in terms of the fibroscan that they did.
Okay, having said that, I mean, the dose that I am aware that they used was very high, not the dose that you would get off over the counter that you buy.
Yes.
Right?
So generally it's not been standard practice to use high doses, and I think the most important thing is really your lifestyle and the weight loss. There are a lot of other things besides Silimarin that has been found to be beneficial. I think one of the simplest things to do is to have coffee. Coffee. Coffee is actually very good for your liver. You can take as much as you want. And even if you look at the American guidelines for hepatitis C, in the American, they actually say taking coffee. And we actually tell you to take 3 cups a day. You can take as much as you want. Really? What you have in the coffee is something called polyphenols. And interestingly, the structure of polyphenol is exactly the same as Silimarin.
You've just increased the stock of products.
Yeah, so it's actually quite good. So, and there's so many others. People have even talked that green tea, turmeric, ginger, garlic.
Yeah. What about those?
They all have got small studies that show they are antioxidant, they're anti-inflammatory. Most of them do bring down your ALTs and ASTs, but they do not translate to reduce morbidity and mortality. The thing to remember in NAFLD, non-alcoholic fatty, those who have got simple steatosis, their all-cause mortality is the same.
Okay.
The ones that have an increased mortality is the NASH. Okay. So really, when you're managing a fatty liver, you really want to be finding out who are the NASH patients for which you need to concentrate on. The ones that just have got a simple steatosis with no inflammation, their liver is not going to kill them.
Right.
So those are ones you don't have to worry about, bearing in mind that they can still progress into NASH anywhere down the road. Right. So they still need to be monitored, but they are the ones that don't have an increased all-cause mortality.
So your most common management plan is to refer to the dietitian for weight reduction? Yes,
weight loss, whatever way we can achieve it, and of course exercise is just as important. There are a lot of medications that have been tried for NASH, and the commonest ones are things like vitamin E, which has been used in the PIVENS trial, but unfortunately there were some concerns about increased all-cause mortality. hemorrhagic stroke, prostate cancer. So there's some, and of course your diabetic medications like pioglitazone again causes concerns with weight gain, heart failure, bone fractures. There have also been some data coming out on your GLP-1 analogs. Again, not much data, but there have been some, but the most important thing is weight loss, because if you lose 10% of weight loss, you actually lose a lot. You reduce inflammation, and even if you do have fibrosis, that does not progress. So the simplest thing to do is 10% weight loss is a tremendous benefit to the health of your liver.
10% weight loss, that's the one to remember.
Yes.
Okay, so Puan Nurul, how do you get that 10% weight loss that Dr. Ganesh wants?
Okay, thank you, Dr. Chan and Dr. Ganesh. All right. Okay, we'll move on to the next slide. I'm just going to show you a little bit what SJMC weight management program offers. So we do have a new program that we have actually established for the last 3 months. All right. So this particular program will take the duration of 10 weeks once a patient registered, and usually the cases that so far we have seen 15 cases, and I must say that they are actually doing very well. We do see probably not 10% within these 10 weeks. We actually aim weight loss 10% between 3 to 6 months. Yeah, okay. And basically the services is like one-to-one consultation, and we do see patients for 5 visits with a gap of every fortnight. Yeah, and we do also follow up with patients via WhatsApp video call just to see how the patients are doing. And next slide. Okay, so the areas that we cover, yeah, okay. When the patients are being referred to us by Dr. Ganesh, we will do the anthropometric measurement, yeah. But this particular anthropometric measurement is not just a simple taking patients' height and weight and just calculating their BMI, okay. We have actually invested on a machine called InBody. It's a body composition analyzer. So with this particular InBody machine, you'll be able to determine patient's percentage of body fat versus muscle mass, okay? So these are the current indicators that we're looking at in terms of measuring weight management or weight loss success. It's no longer BMI, yeah, okay? So apart from that, my dietitians are also trained to do nutritional focused education, where we'll be discussing on issues, for example, emotional eating, you know, how do you deal with comfort food, you know. So these are the areas that we will educate the patients, yeah. And the most important thing in order to ensure success, you need to have cognitive behavior therapy. Okay, so this is actually a psychotic therapy that is used, and we will actually ask patients, okay, what are their problems and how do they plan the right strategy to manage their eating behavior problems, yeah. And once we have actually concluded how do we deal with this particular patient, we will do a proper meal planning and consultation, yeah. And we will actually give out a diet plan, and the diet plan will be very tailored according to individual. And if you want to manage weight loss, usually the range of calories that will be prescribed by the dietitian is between 1,200 to 1,500 calories, where we will spell out in terms of, you know, the carbohydrate proportion, the protein, and the types of fat that patients should consume. Okay. So this is the current thing now, where it's no longer just looking at BMI. Dietitian needs a body composition analyzer. So basically, this is the right tool to assess the body status of the population. And you look at the body composition, not the weight, you know, no longer BMI. And by using InBody composition analyzer, it is an effective tool to educate the population. Yeah. So it allows us as a dietitian to evaluate the participant's body in detail, because it will give you breakdown in terms of what is the muscle percentage and the fat percentage at your upper trunk and your lower trunk, your left arm, your right arm, you know, and all that to identify achievable goals and increase success of the nutritional plan. and we will basically monitor the weight management. Yeah. All right. So next slide. Okay. So this is basically the current thing that we're looking now. Percentage of body fat or diagnosis of obesity. So for a male, the normal range of body fat percentage which is allowed is just between 10 to 20%, whereas for female it's slightly higher, 18 to 28%. Yeah, okay. So for a BMI of 26 kilograms, all right, per meter square, the patient will classify as overweight. But if the body fat percentage is just between 17.2%, if talking for a male patient, then patient is actually within the normal range. Yeah, okay. So we need to tell this to patient, yeah, because a person who is muscular tends to be categorized as overweight when using BMI, whereas if you take a look at the body fat percentage, it is actually within normal range. So these are the things that we need to educate patients. It's no longer using BMI alone. Yeah. All right. So in terms of monitoring the patient success, next slide. All right. So this is what we do. All right. We monitor the body fat percentage, and let's say if the weight maintained, yeah, but if the patient reduce the body fat mass, yeah, reduce body percentage of body fat, all right, still consider a success, yeah. But if the patient losing muscle mass and increase body percentage of body fat, so it's not really a success. So this is what dietitians are using in Subanjaya Medical Center to assess weight management, success.
So you're focusing on the percentage body fat in that column there.
Yes, yes.
Right, good. Thank you very much, Dr. Puan Nurul. Okay, as per usual, patients, they disappear on us, and he disappeared for 5 years. And when he returns, he comes with these results. His fasting glucose is 7.4 and A1C is 6.9%. So question 5, I will answer. He has become frankly diabetic, type 2 diabetes, and I'd like to perhaps highlight for those of you who are following this talk that his BMI has gone up some more from 29 to 32. So typical again. Puan Nurul, you didn't succeed in this, gentleman. Maybe at that time you didn't have the inborn.
Yes, yes.
Okay.
Inborn.
Now his liver enzymes show this. Dr. Ganesh, what happened?
Okay, quite typical. As your weight goes up, your transaminases tend to go up. And one of the things we can do if you have a patient who's got fatty liver, whose lefty is deranged, as they lose weight, the liver function tends to normalize, which is really a good way of monitoring whether you're somewhat getting on top of things. So this is not surprising, but looking at his ALT higher than his AST, it still looks like a simple fatty liver, but you should, since he's also a diabetic, you would want to do further tests to make sure that he's not progressing. And I'll talk about how we can use our certain markers using some simple lab tests to decide whether these patients do progress, in which case you can do then further evaluate these patients with maybe transient elastography and even consider doing a liver biopsy in these people who there is a risk of progression of their liver disease.
Let me just take you up on this, on what your quick statement. Because he's diabetic, his liver enzymes, and then you didn't finish the statement. What are you trying to say?
We find that the people with fatty liver, the patients that do tend to progress into NASH and fibrosis and cirrhosis are those who are overweight, those who are diabetic, those who are older, especially they're more than 50, and those who consume significant amounts of alcohol. So these are things that, well, he's got at least 3 of them.
Right. Yeah. Will your management change, or will you stick it back to Puan Nurul?
Oh, back to Nurul.
Back to Nurul. Nurul, yeah. Would you change your diet advice given his current biochemistry, or would you just hammer him a bit harder?
Okay, so in the first place, we have to look at the BMI, right? Patient is basically within obese grade 1. So usually what we will advise, we need to bring the BMI to overweight group to at least 29.9. And other than that, we will actually spell out where we need to make sure that he needs to reduce his total fat intake in the diet since the AST and ALT is increasing since the last 5 years. And usually I will spell out more in terms of the types of fat that he needs to consume in his diet, all right? So usually we will tell the patient, you got to make sure that your intake of, your fat is not more than 30%, and we will spell out the types of fat that patients need to focus. To reduce saturated fat, obviously from the animal fat, the santan, the typical fried food, and to focus more on the usage of MUFA, monounsaturated fatty acid types of fat, and also polyunsaturated types of fat. And in order to help with the weight management, usually the simple way now, I guess everybody is very familiarized with this suku separuh hashtag, where we actually tell the patient to actually draw your plate. And in order for you to know how much you should take in a day, you change your plate into quarter carbohydrate, another quarter will be your protein, and half of it you fill it up with different fruits and vegetables. And I will tell patients to go for different colors of vegetables to get the different types of phytonutrients and antioxidants.
I've always thought that fatty liver, part of the problem was too much carbohydrate, because the data that I know seems to be that the carbohydrate drives the triglycerides into the liver.
True. And in this particular case, we will actually tell patients not to consume more than 50% of carbohydrate. And the carbohydrate, we focus more on complex carbohydrate, where you ensure your types of carbohydrate are mainly from the whole grain. For example, you tell patients instead of white rice, you go for brown rice. Instead of white bread, you go for milk bread. There are all these whole grain types of pasta and spaghetti available nowadays. And instead of white flour, you go for atta flour, So these are the options that we will actually tell patients.
So your main emphasis is reducing calories for the purpose of weight loss, changing the types of fats that he takes from saturated to monounsaturated, and again, the correct type of carbohydrate and your suku setengah.
Yes.
All right, separuh. Right. Now let me bring Dr. Jayamala before she falls asleep. Do you think that do you think he's a high risk for cardiovascular disease, Jaya?
Obviously, yes. His father went for a bypass at 49, and this young man is just entering into his 40th year. So obviously, he's probably at this point in time more worried about his heart than he is of his liver. And if you look at it, he's diabetic. Look at all his CV risk factors. He's a diabetic. He's got blood pressure. He's got a positive family history, and a positive family history has got actually carries probably more significance as a CV risk factor than some of what we know. Does he smoke? I think he
smokes.
He smokes. Lagi.
So there's a time bomb for heart disease.
Yes. First thing, of course, is to do a simple ECG and a stress test. A stress test has its limitations, but in the stress, what I often use is a stress test as a gatekeeper. If the stress test becomes abnormal at very low or medium workloads, that sort of patient will probably need an invasive coronary angiogram. Whereas if it is abnormal at very high workloads, then maybe we could do a CT. Would I just do a CT in this young man? I think that is something which can come up for discussion, because his father had heart problems in 49. At this point in time, I may defer it, but maybe over the next few years, it may come up for discussion that for better CV risk assessment, if he continues to be asymptomatic and his stress test is still very good, it means it's negative at adequate workloads, it may require at least a calcium score for a better CV assessment.
So you definitely think he's a very high-risk individual, and you have already elucidated all the clinical risk factors that he has. But if he is asymptomatic, and his stress ECG is only positive at very high workloads, then you may not proceed to any invasive.
No. Let me just correct you.
Yes.
If it is abnormal at very high workload, then I would do a CT coronary angio. If it is abnormal at low or moderate high workload, I would do an invasive coronary angio. If the stress test is negative at an adequate workload, then I would ask him to address the CV risk factors, and in the next few years, if he doesn't improve in terms of his risk factors, then there's discussion about using the CV, at least a calcium score, for a better risk assessment may turn out.
Got it. So high risk, assess him appropriately, manage aggressively his cardiovascular risk factors.
Correct.
Right. Thank you very much. So now let's proceed to case 2. We'll have other opportunities to discuss in more general terms. So here we are, Dr. Ganesh, an older individual, 63, already long-standing diabetes, hypertension, 20 years, comes to you with abdominal distension, bilateral pitting edema of 1 month's duration, lost appetite, very lethargic, but has no chest pain, no symptoms refer system, non-smoker, has been a teetotaler, is on all these medications already, okay? And on examination, his BMI is 30, pitting edema, no jaundice, BP is like that, he's got spider nevi, palmar erythema, and large irregular liver with a query mass and what appears to be ascites. What is your working diagnosis, Dr. Ganesh?
Okay, so looking at the presentation, sounds like this patient has got decompensated liver cirrhosis, as evidenced by the ascites and the ankle edema, and with the irregular mass in the epigastrium, one has ruled out hepatocellular carcinoma, which is very prevalent in people who are cirrhotic.
So here we are. This is the data that we get of him. His platelet is low, albumin is 27. These are his enzymes. Prothrombin time is normal, renal profile is normal. Abdominal ultrasound, would you like to discuss this?
Okay, so if we look at the blood investigations, it looks very cirrhotic. And the reason I tell you that is if you look at the blood counts, he's sort of pancytopenic. Low platelets, low white cell count, low hemoglobin, and there's probably an element of hyposplenism. His albumin is low, his bilirubin is slightly high, AST is higher than the ALT, and his alkaline phosphatase is significantly elevated. What we find on the ultrasound is epigastric mass, which is probably hepatocellular carcinoma. He does have portal hypertension with a slightly enlarged spleen. Portal vein is thrombosed, which we tend to see in cirrhotics, and more so in people who have got hepatocellular carcinoma. And he does have ascites. So he is a decompensated liver cirrhotic.
And what is this about the cirrhotic screen, Dr. Ganesh?
Okay, so basically, it's a cirrhotic screen because there are a lot of other causes for liver cirrhosis. The commonest being hepatitis B and C and alcohol. Of course, in summary, you also have to rule out other rarer diseases like Wilson's disease, autoimmune hepatitis, hemochromatosis, alpha-1 antitrypsin, and all those things.
You do that in this individual?
Well, I probably wouldn't, but at least I would look for something that's treatable, like Hep B, Hep C, autoimmune. But I guess my options are very limited in terms of treatment because his liver is so, he's a child C cirrhotic that's decompensated big time. So I think our options are very limited, except if anything, a liver transplant.
Yeah, so, you know, this poor woman, actually female, is so far down the line that we want to try and learn from this. Could this problem have been prevented, Dr. Ganesh?
Yes, it could if we had picked up the cirrhosis early. And that's the hard part. So one of the main emphasis in managing fatty livers, NAFLD or MAFLD, is you really want to pick up or differentiate the NASH from the simple steatosis. The reason being the NASH, they progress and they are cirrhotic. So once you know they're cirrhotic or they've got significant fibrosis, then two things happen. One, they need to go on liver cancer surveillance, which is an ultrasound every 6 months. They also go on surveillance for portal hypertension, esophageal varices, which means we put them on beta blockers to reduce the risk of variceal bleeding. So had this been picked up earlier, chances are we would have picked up a small tumor much earlier, resectable, curable, could have done RFA or interventional radiological intervention or resection, which could actually have made a big difference.
Okay. So, right, I think let's go back to more general terms. This one, we chose two different types of patients. One, what appears to be early when NAFLD haven't quite progressed to steatohepatitis. Dr. Ganesh, few important points I think you need to get the GPs to understand. How do you differentiate between a NAFLD versus a NASH? And are there any tests that the GPs can use? And when do you think they need to be referred to you?
Maybe we can go on to my slides then. Okay, so this is the definition. So basically, if you talk about NAFLD, basically it's more than 5% steatosis in your liver. And the only way you can really be sure of that is, of course, a liver biopsy, which will tell us whether it's simple NAFLD or is there significant inflammation causing fibrosis. So what we need to do is look at the patient and decide whether there's significant steatosis. Where do they fall into? Are they a simple NAFLD, or are they one of those that have got NASH? And if they do have NASH, then they do have a risk of hepatocellular carcinoma. And NASH, of course, will depend on, basically there's hepatocyte ballooning and there is fibrosis. And fibrosis can be categorized as early, middle, or cirrhotic, of course, which is F4 fibrosis. So this is how you actually can have the different stages of the whole spectrum, from a simple steatosis to the other end, which is non-alcoholic steatohepatitis. And now there have been a lot of different histological classifications for fatty liver, but again, we're trying to move away from that to come to a standardized histological classification for any liver disease, which is based on the stage of fibrosis and the grade of inflammation. So probably in the future, you'll just grow across to how much inflammation, how much fibrosis there is.
Okay, so at the moment, I still don't know how to differentiate. Would you like to show me?
Okay, so for somebody who's seeing a patient with fatty liver, you can do a few tests. First thing is to find out whether this patient has got fatty liver. And the simplest thing to do is actually to do an ultrasound. The question will be, would everybody have an ultrasound in their clinic? Not necessarily. So if you don't have an ultrasound in your clinic, one of the simplest things you can do is something called the fatty liver index, which is again a calculator that you get online, which is based on 4 parameters, which is the waist circumference, the body mass index, the gamma GT, and the triglycerides levels. So just based on these 4 readings, you can put it into the calculator and it gives you a reading. If the reading comes out as less than 30, fatty liver is extremely unlikely. If it's more than 60, fatty liver is very unlikely. So this can be used as a guide in sort of something to help you decide whether this patient could have fatty liver in the absence of an ultrasound scan in your clinic. So if you do have an ultrasound and we do have fatty liver, so what you need to decide is, which patient has got simple fatty liver and which patients are the one that could have the risk of progression. Two of the commonest, simplest scores that we can use is what's called the NAFLD fibrosis score or the FIB-4 score. They're just based on simple parameters such as your age, BMI, AST, ALT, platelet count, and albumin. So the NAFLD fibrosis score uses more parameters than the FIB-4 score. And you come up with a reading based on a calculator online. So based on these readings, whichever score you use, we give you a reading. And so if it's a low reading, then it tells you that the risk of chances of this patient having significant fibrosis or fatty liver, NASH is high or low. So you decide whether it's low risk, high risk, or indeterminate. So if they're low risk, you probably can just keep an eye on them. It's the ones who are indeterminate or the high probability that these are the ones that you need to refer, and these are the ones that need to be further investigated to see whether they've got significant fibrosis, do they have cirrhosis, and and that should be followed by hepatocellular carcinoma surveillance and surveillance for varices and putting them on beta blockers. So really, this is to pick up the indeterminate and the high probability that need to be referred, and the low probability can probably be just monitored.
Your recommendation is to try and look up the internet for NAFLD fibrosis score or FIT4 score and very, very simple parameters that we run off in most commonly done blood tests, isn't it?
Yeah, so this can be done at any clinic, and it can sort of guide you as to which are the ones that you're not so worried about, which are the ones that you need to really watch and keep an eye on, and who can progress.
So this is the one slide that everybody needs to take particular attention on. Okay, what about this then?
Okay, so if you see somebody who's got fatty liver, if you do an ultrasound scan and they don't see, there's no steatosis, liver enzymes are normal, then you're not so worried about them. You probably just keep an eye on them every few years, repeat their liver test. And of course, this is especially somebody, you're considering people who've got metabolic risk factors. So they're really somebody who's got any of the metabolic risk factors. You will have to keep an eye on them to make sure they don't develop fatty liver or they do not progress. If you do an ultrasound scan and they've got steatosis and they do have normal liver enzymes, you still need to assess and see whether they have got a risk of progression, and you do either a NAFLD fibrosis score or a FIT4 score, bearing in mind that people with normal liver enzymes can also progress. So if you do those scores and the readings are extremely low, then they're low risk, you keep an eye on them. You just follow them up with liver enzymes and do the markers again every couple of years. However, if the FIT score or the NAFLD fibrosis score comes out as indeterminate or high risk, these are the ones that you want to be careful about, because these are the ones that can progress, end up being cirrhotic, and end up with risk for liver cancer. So these are the ones that should probably be referred. Now, a lot of the guidelines, especially the European and American guidelines, do recommend that the minute your liver function is abnormal, they need to be referred to a specialist.
You die.
Yeah, so I don't think that's a very practical answer. So I think if the liver enzyme is abnormal, but if you do the fibrosis markers and they're really a low risk, I think it's reasonable to just keep an eye on them. And if they do progress, at that stage, fair enough. You do have to keep an eye on them. Having said that, one of the things to remember is studies do show that if you do have simple fatty liver, you can develop fibrosis by 1 grade. You progress by 1 grade every 14 years.
14 years?
Yes. But if you've got NASH, you progress 1 grade every 7 years. So, and of course, if you've got hypertension, that doubles. So the message is that if you have a simple fatty liver, it doesn't mean there's no progression. There's still a risk you can progress, a bit much lower.
So you tick all the little boxes, yeah?
Yes.
So we want to try and keep some time for questions and answers, Ganesh. So you want to quickly run through this? Okay. So again, weight loss most important. Try to achieve a minimum of 5% weight loss to get some improvement in steatosis. In fact, it is said that if you lose 10% of your body weight, you actually lose 80% of the fat in your liver. That's supposed to be quite, To reduce inflammation, 7 to 10%. So generally, it's a good aim to a ballpark figure, say 10% weight loss. And generally, it's been found that if you lose 10% weight loss, your fibrosis actually does not progress. So weight loss is really the most important. Exercise, generally, yes, any exercise, both resistance and cardio. 150 to 200 minutes a week, 200 minutes a week, 3 to 5 sessions. That's a standard exercise. Yeah, the usual. And of course, bariatric surgery, which I think you all talked about. Previously. So you wrote here in this blue panel, no drugs approved for NASH.
Yes. So if we look at any of the guidelines, there's nothing. Of course, there are a lot of things that are coming out. I think people are optimistic that there are a lot of antifibrotics coming out, but nothing is that the standard of care, lifestyle is the most important. Things like vitamin E, pioglitazone, they mention the guidelines, but we don't know how long, when to give it for, when do we start. But generally, it's really for the NASH. So I think the take-home message really is to try and differentiate NASH from the simple fatty liver. The ones that are simple fatty livers, don't even worry about it because their all-cause mortality is the same. They're not going to die from anything. Of course, they may die from cardiovascular diseases. So NAFLD, nothing. In their NASH, the commonest cause of mortality is cardiovascular diseases. In fact, it is said that about 40% die from heart attacks and strokes.
And they don't live long enough to get the liver cirrhosis, do they?
Most of them don't. So the second commonest cause of NASH is actually non-hepatic malignancies.
Huh?
So the commonest is cardiovascular disease. So if you've got NASH, most 40% die from cardiovascular disease. About 25% die from malignancies outside the liver.
Because of the metabolic syndrome and all the obesity related.
So it's a risk factor. So actually some studies show a small percentage only die from liver disease, which is why really spending your time on supplements is probably not the most, not the wisest thing to do for your patient. You know, it's concentrating on other things.
Thank you so much, Dr. Ganesh. I'd like a few final words from maybe a couple of statements from Jaya and Nurul in terms of your role and how you can contribute. Nurul first?
Okay. The doctors out there, kindly refer your patients to our weight management program. There is something which is actually affordable, which is because in order to make it a success, we need to make sure that it is affordable and doable. And basically it's just a 5 sessions of program, and we will actually tailor it according to patient's medical condition, and we do have different types of approach depending on patient's compliance. We realize that the patient is a little bit slow in terms of compliance. We also have a program where we will put patient on meal replacement, which is actually available. Thank you.
My last question, Jaya, are all cardiologists aware of the elevated CV risk in patients with NAFLD? I'm sorry, don't hammer me.
I like what Ganesh said just now, that the main cause of mortality in patients with NAFLD is not hepatic malignancies, but cardiovascular disease. So it's actually more important for the hepatologist to be aware of the elevated CV risk in patients with NAFLD than the other way around. I rest my case.
So just a final slide. NAFLD is very common. You look for it, especially in individuals with the metabolic syndrome, type 2 diabetes, overweight, obesity, hypertension, dyslipidemia. Look for NAFLD. Be sensitized to this problem. Cardiovascular death is the most common cause of mortality, and I'm sorry, I need to put NASH there. Okay, but we also recognize that it progresses to cirrhosis and hepatocellular carcinoma. We need to recognize when patients need to be referred to the gastroenterologist, hepatologist, but I think everybody needs to be sensitized to this title that we have got, that NAFLD NASH. It has got everything to do with the heart. Thank you very much for your attention. I'm going to pass back to Alan for
We're
Q&A.
going to move over to Slido first, because that's our main Q&A. So the first question for Dr. Ganesh: would tea give the same benefit as coffee in fatty
Good
liver?
question.
It has got to be green tea.
Japanese or Chinese?
Anyway, green tea. So because green tea has got something called EGCG, and it's also got polyphenols, which supposedly is antioxidant, anti-inflammatory. So yes, if you're taking tea, it does help your liver, but green tea.
Okay, tea for me.
Right. Okay. Anyway, I take comfort in my 2 to 3 cups of coffee, even though it's giving me ectopic. But anyway.
So no milk. No milk in your coffee.
Okay. Dr. Casey Nair has asked, a patient whose liver function was normal, but liver enzymes started rising after starting Atozet. LDL 6.8. Lipids all came down, but liver enzymes became abnormal. So,
Jaya,
Okay.
would you like to answer that? I think maybe that to be fair to Jaya.
Okay, all right. So basically, it is possible that the rise in liver enzymes is related to the statin. That means A to Z is a combination of atorvastatin plus erythritol. So one of the things, it's actually this elevation of liver enzymes is completely reversible. If you stop the medicine, it will come down. Number two is this man is going to get more cardiovascular benefits by keeping his LDL right down. So if the liver enzyme rise is not too much, we would normally say about 2 to 3 times baseline, we would actually accept it. Okay, if you're worried, you can cut down the dose of the A to Z a little, as long as his target LDL remains within what you want it to be.
Yeah, I had an exact patient like that. The patient's enzymes actually went sky high to about I think about a few hundreds starting atorvastatin. And I went through the literature. Atorvastatin is slightly higher risk of developing statin-induced hepatitis compared to the other statins. Isn't that right?
Yes and no. I had a patient like that where simvastatin was given simvastatin and it went up to the thousands. He even ended up having a liver biopsy. So that was in Hong Kong. When he came back here, he refused. He ended up with a bypass, but he refused to take a statin. Finally, I managed to convince him to take atorvastatin 5 milligrams daily with ezetimibe 10 milligrams daily, and he's got an LDL which is less than 1.4 now. So it's very well controlled.
So this other lady, this Indian lady, switched from atorvastatin to rosuvastatin, and her liver enzymes went down to normal, and I switched to rosuvastatin, and she was perfectly fine. So think about it.
It is the dose. It is the dose of the medication rather than the medication.
Okay. Right, Dr. Alan?
Dr. Ganesh mentioned coffee. He heard it must be black, no sugar, no milk. Is that correct?
No, it doesn't really matter. It can even be decaf. Because the main thing in the coffee, although it does polyphenol is the main thing, although it works synergistically with caffeine, the main benefit is polyphenol, which is believed to be antifibrotic.
So even in decaf?
Yes, decaf also you still have the polyphenol.
So 50% Malaysians obese, liver function normal, not feasible to send everyone for ultrasound or fibroscan. How to manage such patients?
FIB score. NAFLD fibrosis score.
Yeah, so you can do the fatty liver index, which is just based on your TGs, your gamma GT, your waist circumference, and your BMI. So if that gives you a low probability of fatty liver.
I'm sure there's an online calculator somewhere.
It's a calculator. Just key in fatty liver index, it comes out. It's very easy to use, and you can be a guide. Then if that's positive, you move on to your FIB score and your NAFLD score, then you decide.
Okay. I think that's for the questions on Slido. There are quite a number of questions on Facebook, so we'll just run through them. I'll bring them up. How many percent of NASH patients develop chronic liver cirrhosis? The questions are on screen.
Okay. So NASH I guess the more relevant question would be what percentage of people with fatty liver end up with NASH, progress to NASH. And once you progress to NASH, you have the risk of progressing to liver cirrhosis. So some studies have shown as high as 25% of fatty livers can progress to NASH. And of course, that is more likely in the obese who are diabetic, who are older, who consume significant amounts of alcohol. So really the thing to do would be really to look out for these who have got significant risk of progression and concentrate on, make sure you rule out there's no progression in this category of patients.
Okay. Next question is there a role for fibroscan before initiating treatment in this patient? I'm not sure which one. I think one of the ones presented. Otherwise, how do you follow progress? Because some may have liver fibrosis, which is more justifiable for treatment. Any comments?
What treatment?
I'm not sure.
The way I look at it, I think a fibroscan is useful to, if your FIB score, your NAFLD fibrosis score, any of them show that there's risk of progression or possibility of NASH, yes, a fibroscan is useful to see whether they do have significant fibrosis, sort of doing a liver biopsy. There also something else that we talked about, which I have not talked about, which is actually something like a fibro test, which is a blood test that does a lot of markers to tell you whether there's significant fibrosis. And you can use that. So even if you don't have a fibroscan, you can do a blood test to see whether there's significant fibrosis. And if there is, you can repeat the fibroscan for the monitoring generally every 2 to 3 years. And while you do intervention such as weight loss, and you see that you manage to lose weight, you may see some amount of, it may not progress, or there may actually be even some improvement in the FibroScan.
Question on in-body machine is expensive. So is it worthwhile if test is included in SJMC? Otherwise, weighing scale in Shopee or expensive.
Yes, the machine is expensive, but our charges are affordable. Yeah, they have actually a few range of in-body. So the one that we get is actually one of the higher end, and it's basically very accurate and very comprehensive. So do come over to SJMC for this weight management program.
But seriously, the question which is asked, the weighing scale in Shopee, is it also gives you all right information?
I'm just a little bit afraid when it comes to anything that you purchase via online.
So from that just now, I think I put you out the stream,
Yeah.
so I think your answer was not heard, the first one.
Okay, all right. So we talk again about the in-body.
Yeah.
Okay, so in-body is pretty much expensive, but it's actually worth to purchase. The one that we have in our center is actually quite a high-end one, and it will actually give you a very comprehensive result. Yeah. And when it comes to weighing scale in Shopee, one thing that whatever that you purchase online, the issue is in terms of calibration. If it's not well calibrated, it might give you a false result. Yeah. So try not to depend on something which is you purchase online. That will be my answer for anything via online.
That is the way of shopping now.
Let's move. Is fructose from fruits harmful in fatty liver?
So maybe this is for a dietitian. Okay, so fructose is obviously derived from fruits. Yeah. When it comes to fructose or sucrose, all right, especially sucrose, all right, in fatty liver, the recommendation is actually to go less than 10%. But then we have to play by the ear. We have to look at the biochemistry results. If you happen to have hypertriglyceridemia, all right, it's actually best to reduce your percentage of simple sugar. Yeah. And of course, some people will say that you can replace your sucrose with fructose, all right? So bear in mind, it's still a form of sugar, and we do encourage the intake of fruits in the daily diet, but however, we need to actually calculate it. We need to actually calculate what is the proportion that will be suitable for a patient. So it's very hard to actually answer this in general. It's best for the patient to come over to see a dietitian so that we can actually plan a proper meal planning for the patient.
I think again, I'd like to re-emphasize that fatty liver, the fat in the diet is important, but the carbohydrate in the diet is just as important to restrict, because we are aware that in fact the scientific research suggests that if you restrict carbohydrates for even as short as 2 weeks, and you can see the fat actually literally melt away from the liver. But the issue is whether it's a sustainable diet. So the key is, when you ask all these specific questions regarding fructose, regarding other carbs and stuff like that, the general policy has to be restricting these nutrients that could potentially aggravate the fatty liver.
You are using the term fibrosis marker. Does that mean the patient needs liver fibrosis, or otherwise not a blood test? I'm not sure whether it's referring to the score or what.
Yeah, so the fibrosis markers, this is a score, either the NAFLD fibrosis score or the FIB-4 score. When we want to do a blood test, you can, but it will also give us something similar to like a FibroScan. But the simplest thing to do in your clinic would be to probably do any of those with your simple parameters like your transaminases and your sugars and your BMI.
I just Google, and then I think you just Google for this one, that fibrosis for FIB-4 calculator. I think you can find plenty online.
All online.
Yeah. Okay. So let's move. I think a lot of comments, questions. What to do with statins when patient already on and later detected NASH?
continue.
Yeah. So definitely continue. In fact, there's some studies to show actually statins actually reduce fibrosis in your liver. So definitely continue. The only time I would stop a statin if they get decompensated liver cirrhosis.
Question for Nurul. Do you refer patients for exercise to complement your nutritional management?
Yes, yes. Usually, exercise needs to go along with the nutritional plan. And basically, we do emphasize for patients to actually purchase or get all these devices where you can trace your steps. The easiest is actually to go for 10,000 steps in a day. And of course, some of our patients, they are actually seeing their own personal trainer. Some of us do that, yeah. But in general, we will basically tell patients to encourage steps, try to achieve 10,000 steps in a day, and to focus on cardio types of exercise to lose weight.
Okay, for the first patient, any role of metformin, statin, vitamin E besides non-pharmacological treatment?
No, there's no role for metformin in fatty liver. There's been no benefit. Neither statins or vitamin E. Because the first patient actually sounds like a very simple fatty liver. I don't think there's any inflammation. So I don't think there's a reason to treat him except to advocate lifestyle changes in him.
So that he does not progress.
That's right.
Alan, what happened to you?
No, those offline. Okay, sorry. Next question, we better move on. Does intermittent fasting help?
Oh, that's a good question. So I think the answer to that is, while Nurul is trying to figure her video, is anything that lowers caloric value in a day, which will then result in weight reduction, is the way to go. And as you've heard, I think the main message to take home is lifestyle, weight reduction, weight management, i.e. weight reduction, which has been scientifically improve fibrosis. And what did Ganesh say? 10% reduction in weight, and you will lose 80% of the liver fat, and the fibrosis will not progress. Right? Those messages need to go home. So intermittent fasting, any other fasting, how would I say, program or whatever the patient uses, which ends up being hypocaloric, less calories than they require in a day, that results in weight reduction, will help. Does that answer your question? So it can be intermittent fasting in whatever manner that you hear, 16-8, 5-2, whichever way. The most important to follow up is that it has to be sustainable. Don't do something that you cannot sustain.
The keto diet fad has them consuming veg oils, olive oil, coconut oils. Will this worsen their NAFLD?
Good question. Anybody?
Well, the only thing I can say generally that's protective in terms of fatty liver, in terms of diet, we say it's a high fiber diet and a diet that's rich in natural antioxidants. So the keto diet, I mean, whatever that makes you lose weight, whatever works, is really your end point.
Yeah.
But I don't think it's going to worsen your NAFLD because you're taking all these oils and all that.
Yeah, I agree with that.
I think that's coming to the end of the session. I will now share the slides again. Let me present. Okay, so right, that's the QR code, folks, for today's talk. Now you can take out your MMA app and scan for points. Yeah.
Okay, now first point for the year.
This is the first month. The CPD cycle starts 1st of July for the current year until 30th of June next year. So for last year until 30th of June last month, you should have collected at least 20 points. If you haven't got 20 points, too bad, there's no exemption. So no exemption, except certain circumstances, we have to write into to the MMC. So the 20 points you didn't get,
points to sell.
cannot sell points, but we give away points free. We attend the SJMC grand rounds every month, and all our CBD activity. So please can help your colleagues by liking the video. All right, if you like, Facebook and YouTube algorithm will help spread. That's the way it works. Okay. And let me turn off this. Okay. The video will be hosted on YouTube and Facebook. So even if you miss the beginning, you can scroll back and play and watch. So, all right. So we'll be stopping the broadcast shortly. Hope you all like our new backgrounds.
Lovely.
We got a new background.
The lime green is very attractive. Dr. J, lime green.
Upload. No, but the screen, the thing is
Okay. All right. We'll start. Thank you, everyone.
Thank you.
Thank you, everyone, for watching. We're going to end the broadcast now. So the CBD QR code is still there. You can still play back the video, but it will expire in about half an hour or an hour. Then the code will no longer be valid. Okay.
If you do now, you get 1 point as an audience, and then Kevin will give